Thyroid cancer. Epidemiology. Thyroid cancer is the most common endocrine cancer and the ninth most common cancer overall. The American Cancer Society estimates that about 64,300 new cases of thyroid cancer will be diagnosed in the United States in 2016, 49,350 in women and 14,950 in men. Thyroid cancer represents 3.8% of the new cancer cases. Although most cancers are either stable or declining in incidence, the incidence of thyroid cancer continues to increase. Rates for new thyroid cancer cases have been rising on average 5.5% each year over the last 10 years. Death rates have been rising on average by 0.8% each year from 2002 through 2011. Despite standard treatment, an estimated 1,980 deaths from thyroid cancer, 1,070 women, 910 men, will occur in 2016. The prevalence rate for occult thyroid cancers found at Autopsy is 5% to 10%, except in Japan and Hawaii, where the rate can be as high as 28%. Autopsy rates do not correlate with clinical incidence. Most patients are between the ages of 45 and 64 years at the time of thyroid carcinoma diagnosis. Median age at diagnosis is 50 years. About 2% of thyroid cancers occur in children and teenagers. Women are affected more often than men, 3-to-1 ratio, and are usually diagnosed at a younger age. The most common stage at diagnosis is localized disease, confined to the thyroid, in 68% of cases, followed by regional disease, spread to regional lymph nodes, in 26% of cases, distant metastases in 4%, and unknown in 2% of patients. The 5-year survival for patients with localized thyroid cancer is 99.9%. The overall survival depends on stage, age, and in patients with differentiated thyroid cancer, the ability of the tumor to take up radioactive iodine, RAI. The 10-year overall survival is significantly reduced to 10% in patients who are older, have distant metastases, macronodular lung metastases or bone metastases, and are RAI non-avid. The prevalence of thyroid nodules in the general population is 4% to 7%, with nodules more common in females than in males. The prevalence of thyroid cancer in a solitary nodule or in multinodular thyroid glands is 10% to 20%. This increases with irradiation of the neck in children and older men. See section on etiology and risk factors. Tumor types. Thyroid cancer is classified into 4 main types according to its morphology and biologic characteristics. Papillary and follicular carcinomas, also known as differentiated thyroid cancers, account for more than 90% of thyroid malignancies and constitute approximately 0.8% of all human malignancies. Medullary thyroid cancers represent 4% of all thyroid carcinomas. About 75% of patients with medullary cancer have a sporadic form of the disease, the remaining 25% have inherited disease. Anaplastic carcinoma represents less than 2% of all thyroid carcinomas. Papillary thyroid carcinoma. Papillary thyroid carcinoma is the most common subtype, and it typically has an excellent prognosis. Most papillary carcinomas contain varying amounts of follicular tissue, since they derive from thyroid follicular cells. When the predominant histology is papillary, the tumor is considered to be a papillary carcinoma. Because the mixed papillary follicular variant tends to behave like a pure papillary cancer, it is treated in the same manner and has a similar prognosis. Papillary thyroid carcinomas are unilateral in most cases, but they also can be multifocal. They vary in size from microscopic to large cancers that may invade beyond the thyroid tissue and infiltrate into contiguous structures. Papillary tumors tend to invade the lymphatics, but vascular invasion, and hematogenous spread, is uncommon. Up to 40% of adults with papillary thyroid cancer may present with regional lymph node metastases, usually ipsilateral. Distant metastases occur, in decreasing order of frequency, in the lungs, bones, and other soft tissues. Older patients have a higher risk of locally invasive tumors and of distant metastases. Children may present with a solitary thyroid nodule, but cervical node involvement is common in this age group. Up to 10% of children and adolescents may have lung involvement at the time of diagnosis. Follicular thyroid carcinoma. Follicular thyroid carcinoma is less common than papillary thyroid cancer, occurs in older age groups, and has a slightly worse prognosis. Follicular thyroid cancer can metastasize to the lungs and bones, often retaining the ability to accumulate rye, which can be used for therapy. Metastases may be appreciated many years after the initial diagnosis. Follicular thyroid carcinoma, although frequently encapsulated, commonly exhibits microscopic vascular and capsular invasion. Microscopically, the nuclei tend to be large and have atypical mitotic figures. There is usually no lymph node involvement. Follicular carcinoma can be difficult to distinguish from its benign counterpart, follicular adenoma. This distinction is based on the presence or absence of capsular or vascular invasion, which can be evaluated after surgical excision but not by fine needle aspiration, FNA. Hürthle cell, or oxyphil cell, carcinoma is a variant of follicular carcinoma. Hürthle cell carcinoma is composed of sheets of Hürthle cells and has the same criteria for malignancy as does follicular carcinoma. Hürthle cell carcinoma is thought to have a worse outcome than follicular carcinoma and is less likely to concentrate rye. Medullary thyroid carcinoma. Medullary thyroid carcinoma originates from the C cells, parafollicular cells, of the thyroid and secretes calcitonin. Secretory diarrhea and flushing, related to secretion of neuroendocrine peptides, are clinical features of advanced medullary thyroid carcinoma in 30% of cases. On gross examination, most tumors are often found in the upper two-thirds of the thyroid gland and are firm, grayish, and gritty. Hereditary medullary thyroid carcinoma, which accounts for 25% of all cases, typically presents as a bilateral, multifocal process. Histologically, hereditary medullary carcinoma of the thyroid does not differ from the sporadic form, which usually presents as a solitary thyroid mass. However, the hereditary form is frequently associated with a background of C-cell hyperplasia. Another characteristic feature of hereditary medullary carcinoma is the presence of amyloid deposits. There are two hereditary forms, multiple endocrine neoplasia type 2A, MEN2A, characterized by medullary thyroid cancer, pheochromocytomas, and hyperparathyroidism, and multiple endocrine neoplasia type 2B, MEN2B, characterized by medullary thyroid cancer, marfanoid habitus, pheochromocytomas, and mucosal neuromas and gastrointestinal ganglioneuromas. Familial medullary thyroid carcinoma is now considered a variant of MEN2A in which family members do not demonstrate any of the other endocrine tumors. These syndromes are associated with germline mutations of the RET proto-oncogene, which codes for a receptor tyrosine kinase, called retired. Hereditary medullary thyroid cancer is inherited as an autosomal dominant pattern with high penetrance and variable phenotypic expression. For a discussion of genetic testing to screen for RET mutations in men kindreds, see section on diagnostic workup. Approximately 40% of sporadic, non-hereditary, medullary thyroid carcinomas contain somatic RET mutations and 13% will have a RAS somatic mutation, predominantly the HERS type, which may represent potential therapeutic targets. Metastases to cervical and mediastinal lymph nodes are found in half of patients and may be present at the time of initial presentation. Distant metastases to the lungs, liver, bones, and adrenal glands most commonly occur late in the course of the disease. Anaplastic carcinoma. Anaplastic tumors are high-grade neoplasms characterized histologically by a high mitotic rate and lymphovascular invasion. Aggressive invasion of local structures is common, as are lymph node metastases. Distant metastases tend to occur in patients who do not succumb early to regional disease. Occasional cases of anaplastic carcinoma have been shown to arise from pre-existing differentiated thyroid carcinoma or in a pre-existing goiter. Other tumor types. Lymphomas of the thyroid account for less than 5% of primary thyroid carcinomas. Other tumor types, such as teratomas, squamous cell carcinomas, and sarcomas, may also rarely cause primary thyroid cancers. Renal cell carcinoma is the most common extrathyroidal tumor to metastasize to the thyroid. It accounts for almost half, 42%, of patients with this condition. Colorectal cancer, lung cancer, breast cancer, and sarcomas account for 26%, 19%, 11%, and 6%, respectively, of metastases to the thyroid. Females show a slight predilection for metastases to the thyroid from non-thyroidal tumors. Of metastases to the thyroid gland, 44.2% occur in glands with abnormalities, such as primary thyroid neoplasms and benign thyroid conditions. The interval between diagnosing the primary tumors and their metastases to the thyroid gland is 4.5 months to 75 months.